To start trauma grand rounds, and today we're going to be talking about the review and management of facial trauma. Alazinga is going to speak to us on that topic. She's one of our PAs here at the University of Utah Trauma Service. This is her second lecture that she's given for us. She got her training actually back in the Ukraine as a PA, then came to the States and had to repeat it again at Cornell University in New York, and then worked in New York at North Shore Hospital, and now works for us at the Trauma Service, and we're glad to have her with us, and she's going to talk about facial trauma. Thank you.
Thank you, Russ. Hello, everybody. Thank you for tuning in. So, as Russ has mentioned, today's topic is a review and management of the facial trauma. So the objective for today's lecture is kind of go through the significance and incidence of the facial trauma. I'll give you a short course of facial anatomy and physiology, and we'll go over the assessment and treatment of the facial trauma patient. So an estimate 3 million emergencies department visits are made per year for facial trauma, and since most of them are relatively minor, many of those patients likely to self-report to emergency department. As a result, you as a EMS professionals are likely to see fewer than 1% of patients with facial trauma that is significant and accompanied by any other traumatic injuries. Historically, motor vehicle collisions were the leading cause of facial trauma, but increased use of seat belts has seen the number decrease. However, EMS professionals are now likely to encounter MVC patients with less severe facial pain and bruising secondary to airbag deployment. There may even be simple soft tissue wounds from eyeglasses being pushed into their face by the airbag. Nonetheless, motor vehicle collisions continue to be a leading cause of facial trauma for unrestrained occupants. Specific types of facial injuries are associated with a specific mechanism of type of symptoms. For example, MVC collision, physical altercations, and falls lead to about 85% of nasal fractures, and these are the most common type of facial fractures. Fractures to the zygomatic bone are second most common, and predictably, like other facial fractures, most often occur in men in their 20s. Men experience most type of trauma at the greater rate because of the combination of factors, including alcohol and drug intoxication, and risk-taking and confrontational behavior, and lower use of safety devices like seat belts. In some study, it was reported that women tend to get upper facial traumatic injuries if they are involved in an intimate partner violence, or they will get a facial injury of the mid or lower part of the face if they're suffered from motor vehicle crash or being randomly assaulted. So, facial trauma results from blunt or penetrating mechanism, and sometimes both. And also it ranging from trivial to life-threatening, including, as I mentioned, motor vehicle collisions, violent altercations, falls from any height, person-to-person collisions, gunshots, stab wounds, vehicle versus bike, auto versus pedestrian, flash hoods, animal bites, sport injuries, or falls from, let's say, seizures. Geriatric and pediatric patients have their own unique mechanism. Kids experience facial trauma running into walls, tables, counter edges, other kids, and sometimes they get into equipment at the playground. Geriatric patients experience facial trauma secondary to falls because they lack that quick reaction time needed to protect themselves as they fall. So we had a man, 80 years old gentleman, who stood up quickly from his recliner, fell faint, and lost his balance and fell forward, hitting his face on side of the nightstand, and he simply could not react fast enough to brace himself from the fall down. Just wanted to point to your attention to the significance of trauma. Facial bones.
On the pediatric too, some of their trauma is due to that their head is the heaviest part.
Exactly.
I mean, there's a disproportion in that, and so it's the first thing to hit the ground or hit something.
It would be.
As opposed to the other population, you know, middle age and stuff like that, that can control themselves. Their heads are smaller, you know, in comparison.
Excellent point. Yeah. Thank you, Russ. So, trauma, facial bones help protect the brain, house important organs for sight, taste, and smell, create the initial passages of the respiratory system, provide the first action in the digestive process, and are a foundation for communication through the facial expression. While in many situations facial trauma only results in lacerations, abrasions, and swelling, the results can be significant if it also involves damage to underlying bone structures, traumatic brain injury, subdural, epidural bleeding, intracranial hemorrhage, cervical spine injuries, and airway compromises. So quite a few to name. So as far as the facial anatomy, just a quick sort of overview. I think provider that is being called to treat a patient with a facial injury must understand anatomy of the face, and it's very helpful to kind of keep it in the back of your mind. A number of bones fuse together to form facial skeleton. The forehead is supported by a broad frontal bone, and it's a light blue in the picture. The lower portion of which forms the superior aspect or roof of the orbit, or as we call it, eye socket. Two maxillary bones, they're purple, comprise much of the midface support. A small pair of nasal bones, and they're light green, attaches superiorly to the frontal bone and laterally to the maxillary bones, providing structure to the nose. The zygomatic bone, you can see it, it's small, pinkish, or zygoma as we call it, lie between the maxillary bones and the temporal bone of the skull, supporting the cheeks. Portion of the maxilla and the zygoma form the inferior aspect or roof of the orbit. The frontal bone and each maxilla contain hollow cavities, the frontal and maxillary sinuses. The arch-shaped mandible provides structure to the jaw, and the mandible is subdivided into several parts, including condyle, ramus, angle, body, symphysis, and alveolus. The structures of the head are highly vascularized, and they provide rich blood supply to the facial tissue and nerves. Blood supply to the face is provided principally through the external carotid arteries, and is being the venous drainage is provided by numerous veins, and they empty into common trunk to the internal jugular vein. A couple of nerves I would like to mention. It's a trigeminal and facial. Trigeminal nerve, or cranial nerve number 5, has 3 divisions. The ophthalmic nerve is the first division of the trigeminal nerve, and it is sensory, and it supplies skin of the forehead, upper eyelids, and conjunctiva. The maxillary nerve is a second division of the trigeminal nerve. It's also sensory, and that nerve supplies skin of the posterior part of the side of the nose, lower eyelid, cheek, and upper lip. The third division is called mandibular nerve, and it is not only sensory, it's also motor, and it supplies muscle of mastication and skin of the lower lip, chin, temporal region, and part of the auricle. Facial nerve number 7, or cranial nerve number 7, it supplies all the muscles of this facial expression. Briefly, we'll go over physiological functions. So important sensory function, such as vision, taste, and smell, are protected and assisted by the facial bones, muscles, and connective tissue. Injury to the facial bones can acutely and chronically impair those sensations. The upper and lower sinuses are hollow cavities that we call that within several of facial bones that are connected to the nasal cavity through short ducts to allow drainage of mucus. The sinuses are believed to assist with warming and moistening inhaled air and giving the voice resonance. Congestion in those from a cold or allergic reaction results in voice tone changes and the cessation of sinus pressure. Injured facial structures can acutely or permanently impair several physiological functions. In addition to affective sensory organs, facial trauma can compromise ventilation. Mandible and maxillary bones form the oropharynx, and nasal bones are the structure for the nasopharynx. Patients with facial trauma of any cause actually can have trouble communicating because of damage to the facial structures, and they quite often has a profuse bleeding because of that good vascularization. Communication problems can lead to the decreased ability to determine the extent of injury, collect patient history, and understand the patient's mental status. So what are the causes of facial trauma? So the first leading ones are motor vehicle crashes, home accident, athletic injuries. And they also can range from falls, assault, sports injuries, and they're as common in children as well as in adults. They can also be caused by industrial injuries and animal bites.
We used to see a lot too in the rural areas that people would get behind horses and cows and stuff like that, and they'd get kicked in the face because that's where the hoof would come up and just smash them, and they'd have pretty extensive facial trauma just due to that.
And we did have some in within the last year.
Yeah.
So facial injuries, or as often we call it maxillofacial trauma, can be actually classified as a soft tissue injuries and facial fractures. Facial soft tissue injuries often appear serious, but very rarely they are life-threatening, with exception to compromised upper airway and potential for significant bleeding. So those two, upper airway compromise and bleeding, are something that I will go over later in the pre-hospital management, and you will encounter that in your practice very often when you see patients with facial trauma. Soft tissue injuries of the face may include contusions, hematomas, abrasions, lacerations, and avulsions, as well as stab and gunshot wounds. Because of that blood supply, wounds that break the skin are often associated with hemorrhage, which is often brisk but rarely fatal. Although many of these wounds are limited to the skin and subcutaneous fat, deeper wounds may damage underlying structures, including muscles, nerves, and salivary glands. And soft tissue injuries that overlie deformities and point of tenderness or crepitation, if you feel that, may actually represent open fracture of the face. Face. Here's the picture of the gentleman who was clean. As you can see, the picture on the left looks kind of scary, and that's how he looked after he was clean. So it does look kind of gruesome, and you kind of have to go through the mechanism of injury, events leading to the injury, when you're collecting the history. So that will help you clarify exactly what happened to the patient. And it's important for us to know also time of the injury. Specific injuries needs to be addressed within a certain period of time. If patient has any medical problems that we need to be aware of, if he has any allergies. Most of the facial trauma, especially if it's open fractures, let's say mandible, requires antibiotics. So we do need to know if patient has any allergies to antibiotics. And if patient is taking any medication, especially, let's say, Coumadin. And when patient did have a last oral intake as well as when was the last tetanus shot done. So soft management of soft tissue injuries kind of comes to the same ABCD format with the spinal precautions. So you will maintain spinal precautions, you will assess for airway obstruction, use the suction as needed. Sometimes you need 2 suctions. Secure and maintain airway, make sure that patient is breathing and properly oxygenate, and control bleeding. And with the soft tissue injuries, most of the time it's a direct pressure, holding direct pressure, ice, and applying pressure bandages.
Sometimes too, you know, when you get like nose fractures or something like that, I would always have they have profuse bleeding. I'd have the patient actually hold their nose, put pressure on it. You know, you putting pressure on it, you don't know how much it is that's causing that much discomfort, but you allow them to put the pressure on it to control the bleeding, and it works a lot better.
Excellent. Looks like you read my lecture, and this is something I was going to... Yeah, but it's a good point. Yes, absolutely. Yeah, patients who doesn't need spinal precautions can be sitting up and holding, but we'll go over that a little bit of time. So facial fractures, they're, as I mentioned before, they can be blunt or caused by penetrating injury, trauma, but they can be a combination of both. Let's say a little boy, he was running and got bumped into the corner of the coffee table, so he had not only contusion, which is blunt injury, but laceration, which is penetrating. And he could have had, if the impact was big enough, he could have had the, let's say, frontal bone fracture, so there would be a combination of all two, sorry. So causes of injury to the face of the fractures are automobile accidents, most frequent, followed by penetrating injuries and act of violence. So commonly injured facial bones include the nasal bone, the maxilla, and mandible. The mandible may be fractured at the symphysis, body, angle, ramus, and condyle. The zygoma are cheekbone, and the frontal bone are other sites for fractures. And fractures also may occur in bones of the palate and those that come together to form orbit of the eye. So what are the signs and symptoms of the fractures? So when patient has a fracture of the face, he has a most likely he will damage the nerve, and he will have changes in sensation and feeling over the face. If there is a displaced, let's say, nasal bone fracture, so he will have an uneven face and uneven facial bones. He will also have a, for the same reason of the fractured nose, he will say problem breathing because prompt swelling and bleeding occurs. If his orbital, if he has any orbital fracture, he might have the double vision and swelling around the eyes that may cause that visual problems as well. Of course, he will have a pain and bruising, swelling of the surrounding tissues, and asymmetry and loss of function. Fractures of the nose, base of the skull or maxilla may be associated with profuse nosebleeds. Nasal fractures may be associated with deformity of the nose as well as the swelling and bruising, deformity in the face, for example, sunken chin bone, or teeth which do not align properly suggest presence of fractures as well. Asymmetry, as I mentioned, can suggest facial fractures or damage to nerve. People with mandible fractures are often have pain and they have difficulty opening their mouths, and they may have numbness in the lip and chin because of the damage to the mandibular branch of the trigeminal nerve. So back in the beginning of the last century, René Lefort mapped a typical location of the facial fractures. These are now known as a Lefort 1, 2, and 3. Lefort 1 fractures, also called horizontal maxillary fractures, involve the maxilla, separating it from the palate. Lefort 2 fractures, also called pyramidal fractures of the maxilla, cross the nasal bones and orbital rim. And Lefort 3 fractures, also called craniofacial disjunction and transverse facial fractures, those are the most serious and most severe. And Lefort fractures, which occur in 10 to 20% of facial fractures, are often associated with other serious injuries. So don't just be concentrating on the facial fractures just because it has extensive bleeding. Patient might have other injuries that needs to be addressed first. So I'd like to go through some fractures that we see quite often, and I'll start with the frontal bone. So frontal bone fracture, you can see and feel disruption or crepitus of the supraorbital rims. You also can feel for subcutaneous emphysema. Patient will experience paresthesia of the supraorbital and supratrochlear nerves. Patient will also most likely have a frontal sinus injury. Patient will complain of facial pain. You will see lacerations, contusions, and hematomas, and depression of the forehead. Due to the swelling of the face, not most of them, but frontal bone fractures can be missed. And that's why you kind of have to go over your exam, not only you, but us in the trauma centers, and make sure that we're not missing this fracture. Patient can also have a CSF rhinorrhea, and the test to check for the CSF rhinorrhea is to take a piece of the filter paper and kind of put the drop of the liquid that's being tested, and you will see a ring of blood with a larger concentric ring of the clear liquid around that. So that would be a target sign, as we call it, or halo sign, that proves that it's a CSF leak.
Yeah, and CSF also has sugar in it,
so you can
some of the older
right.
have the dextrose sticks and it turns positive, whereas snot and mucus doesn't have glucose in it.
Absolutely. So either one of those can be kind of positive for to prove CSF leak. So we had a 20-year-old gentleman who was in the bar. He got into altercation, was assaulted actually by a cocktail glass. He had a profuse bleeding. His injury was not the facial bone fracture per se, but he did have a laceration over his left frontal bone down to the eyebrow brow and back to the left ear. It was J-type laceration, and he reported himself to the emergency department. He got probably 4 liters of crystalloids, and he was still profusely bleeding. So trauma, we were activated, and his hematocrit dropped down to 24. So he was a healthy young gentleman. So it just to prove that head lacerations can be extensive, even without underlying bone fractures. Another fracture that can be seen is a, as we call it, blowout fracture of the orbit. It involves direct blow to the orbit, sometimes by, let's say, by a fist. As the pressure in the orbit increases, the medial wall or floor may be ruptured, and then it allows orbital contents, including fatty tissue and muscles, to herniate outward. A common fracture pattern involves rupture of the orbital floor, and that results in entrapment of the inferior rectus muscle of the eye. This prevents the eye from looking superiorly when you check for extraocular movements. Because the eyes don't move in unison, the patient may complain of diplopia when looking in certain directions. Another sign of blowout fracture is an enophthalmos, or sinking in the eyeball in the orbit. Although it's often hard to appreciate an acute injury, an orbital fracture may also be associated with a proptosis, or protrusion of the eyeball from the socket. Proptosis usually results from a retrobulbar hematoma and a collection of the eye behind the eyeball, and that may jeopardize sight by stretching of the optic nerve. So these need to be addressed by the ophthalmology once the patient gets to the trauma center. The nasal ball fracture is the most common fracture because of its protrusion from the surface of the face, and the nasal bones are very fragile. And this fracture comprises about 40% of all facial trauma. Signs of the nasal fracture include swelling, deformity, tenderness over the nose. Nasal bone fracture may be associated with, as Ross had said, with excessive bleeding. One concerning complication I'd like to talk about is a septal hematoma, and it's a collection of the blood inside the nasal septum. The blood supplies to the delicate, it's a cartilaginous portion of the nasal septum may be impaired by the hematoma, and that can result in a necrosis of the cartilage. As the time goes on, this cartilage collapses, and the nose develops this subtle deformity. Nasal bone fracture, since it's so in close proximity with the orbits, may have patient can often has a orbital fractures. Fractures of the midface, those are comprises of maxillary fracture, fracture of the zygoma, quite often floor of the orbit because it's being formed by those bones, and the nose is actually also part of the mid-third of the face. Zygoma by itself articulates with the frontal, maxillary, and temporal bones, and it is associated with the orbital fractures as well, and has a similar signs and symptoms of the orbital fracture. So it will have swelling, bruising around the area, facial asymmetry, as you can see in these pictures, and patient also can have a trismus. So patient will have a spasm of the jaw muscle, and that will prevent him or her from opening the mouth, and mouth will remain tightly closed. Zygomatic maxillary complex, or as we call it, ZMC fractures, may include depressed malar eminence resulting in flattening of the cheekbone, as you can see in this radiology picture, and pain upon palpation of the zygomatic eminence. Evidence of the lateral subconjunctival hemorrhage is present as well with those fractures. A step defect is often palpated along the lateral orbital and infraorbital rim, or that zygomatic maxillary buttress. Patient will have a paresthesia of the lateral side of the nose, and quite often upper lip as well, just because of that maxillary division of the trigeminal nerve innervation that can be damaged. And the patient also will exhibit signs of diplopia when you ask him to look up. As I mentioned before, trismus may occur with this type of fracture as well, and you can also see upon evaluation of the intraoral evaluation, you might see a ecchymosis and gingival disruption. So maxillary fractures falls into those Lefort 1, 2, and 3 classification. The signs and symptoms of the Lefort 1 fracture can be a facial edema, mobility of the hard palate and maxillary alveolus and teeth, and that can be diagnosed by simply putting glove and try to move that hard palate. Lefort 2 fracture often present itself again with the facial edema, telecanthus, subconjunctival hemorrhage, again mobility of that maxilla at the nasal frontal suture. Patient may have a nosebleed, and if the fracture is extensive, you might see a CSF leak as well. Lefort 3 fracture, characteristic findings in this type of fracture include massive edema with a facial rounding. Patient's face will be elongated and kind of flattened. An anterior open bite may be present, as you can see on the right side, due to posterior and inferior displacement of the mid-facial skeleton. Movement of all facial bones because of that disjunction of the mid-face in relation to the rest of the skull when you manipulate the teeth and hard palate. You will see nosebleed and majority of time CSF rhinorrhea. Going right along, mandibular fractures will present itself with a painful jaw movement and malocclusion of the teeth. Patient will complain of not being able to open his mouth, and when you ask him to bite hard, he will exhibit that pain as well. Upon palpation, you can feel the crepitus and mobility of that part of the face. Upon intraoral examination, you will see edema again, ecchymosis, bleeding from the gingival bleeding, and the patient may also have tears. So there was a patient, we evaluated him and we found some clear liquid in his right ear. So we thought it might have been CSF leak. Upon testing, it just appeared being his tears. So you do have to be accurate about diagnostic all the anything that you see. An anterior open bite can occur with the bilateral condylar and angle fractures. When inferior alveolar nerve is disrupted, and that can include mental branch of the trigeminal nerve, that can cause paresthesia or anesthesia of that lower lip, the parts that it innervates, chin, teeth, and as well as the mandibular angle, body, and parasymphysis. So again, management of the facial fractures are not different from any other management of the trauma patient that you will encounter. It comes again to the spine precautions. Make sure that the airway is not obstructed and use suction as needed. Make sure that patient is breathing and his oxygenation is above 90%. Make sure that you are controlling bleeding with direct pressure and pressure bandages, and you applying pressure to the nasal nares, or patient can do it by himself as well. So patient can also have a foreign body injuries, and they're very common in children. Some of them, like the one you see, will need attention in the trauma, most of the at the trauma center, but most of them can be evaluated by the primary care physician or at the lower level of trauma care center. You can remove foreign body if it can be easily removed. Otherwise, keep it in place, especially if it can cause extensive bleeding upon removal. And again, do not remove anything from the nose in the field unless it does compromise patient's airway. And if you can remove it without equipment, you can go ahead and do it, but otherwise I would suggest to defer it and bring this patient to the appropriate center.
You know, and little kids too will stick
anything
up their nose and stuff like that. And it's not just like, you know, the micro toys that you can stick in there, but it also they'll stick food products up, get peas up their nose, and then they end up with infections that are horrendous. Yeah, and you have to get that out.
Yeah,
you know, we have them try and blow their nose and blow it out if they could. They're not mature enough sometimes to do that for you, but it can be a problem.
Yeah, they can stick even batteries, and those are dangerous by itself. So those needs to be especially evaluated by the appropriate person. So ear trauma can be seen as a laceration and contusions, usually caused by blunt trauma, but it can be treated with the direct pressure just to control bleeding. You can put ice or cold compress, and that basically to decrease swelling. You can retrieve a wolf's tissue if possible, but transport it with the patient. You can wrap it in a moist gauze, seal it in plastic, place it on ice, and transport with the patient for surgical repair. You can always double check with your with your company and for protocols how to handle those. Here are some examples of, let's say, how the detached pinna would look like, or loss of rim.
You know, and the other problem with ear trauma too is circulation is terrible in the ear. You know, it's mostly cartilage, doesn't have very much vascular supply.
Exactly. So, as I said, some of them needs to be addressed rather earlier than later.
Yeah.
So ear trauma can be caused by thermal injuries, like let's say burns or colds or frostbites, chemical injuries, traumatic perforations, or as the previous picture showed, there might be impaled objects, and also patient can suffer barotrauma, which occur during the airplane trip or while scuba diving. And symptoms of those will include ear pain. Patient may feel dizzy and have a muffled hearing. Common causes of the eye injury are again motor vehicle crashes, sports and recreational activities, act of violence. Patient can be exposed to the all sorts of chemicals that you can find at anybody's home as well. Foreign body to the eye, and animal bites or scratches. So that's why it's really important to evaluate accurately this patient and go over the history of exactly what happened, what kind of mode of injury, if patient did use a corrective glasses or contact lenses. And as a rule of thumb, we would not recommend AMS personnel to attempt and remove contact lenses in patients with eye injuries. Those should stay in, and we'll take care of it here. See if you can test visual acuity in a patient, and first you would test the uninjured eye. You will test the injured eye first and then compare to the uninjured. Check the papillary reaction, and that can be simply done by the pen light. Again, extraocular movement of the eyes is very important to see if there is any underlying fractures, let's say. Specific ocular trauma should be evaluated by the physician, and those include foreign bodies, corneal abrasions, blunt trauma, penetrating injuries, and if there are any protruding intraocular foreign body. Again, do not attempt to take them out, to remove them. You actually would have to support them and bring the patient to the trauma bay with those in place. And the last but not least, the chemical injuries to the eye can cause quite the extensive trauma. So this is how the avulsion of the lid would look like, and it's quite deep. As you can see, it involves lip margin, and sometimes it involves lacrimal duct, and those type of injury needs to be addressed by the oculoplastics. You can also see hyphema. If you can see, there is a tinge of blood right in the anterior chamber of the eye. Those needs to be addressed by the ophthalmologist as soon as possible. Those can be quite extensive, or they can resolve on its own, but needs to be evaluated as soon as possible by the appropriate physician. Also, ruptured globe occurs when the integrity of the outer membranes of the eyes is disrupted by the same blunt or penetrating injury, and any full thickness injury to the cornea, sclera, or both is considered to be an open globe injury. So kind of keep your eyes open for those. Also worth mentioning is the alkaline and acid burns. So alkaline burns those are the most dangerous ones. They have a high pH, which penetrate the surface of the eye. It can cause quite a big injury to the both external and internal structures. Those to include cornea and internal structures like the lens itself. The higher pH chemicals cause more devastating damage. So examples of those alkali chemicals include fertilizers, cleaning products, especially ammonia, drain cleaners, oven cleaners, and plaster or cement. And those can be easily found in any household. Acid burn also result from the chemicals, but with the low pH. It's less severe than alkali burns. They do not penetrate into eye as fast as alkaline substances. Hydrofluoric acid burn is the exception. This one is quite dangerous, and one of the examples of it is a glass polish. So you have to be careful using those, especially if kids are around. Also, other examples include vinegar, nail polish removal. The automobile battery can explode and cause that sulfuric acid burn, which is also has a low pH, and so the acid burns are the most common burns of the eyes.
Those two you want to irrigate.
Exactly.
And those specifically, as you mentioned, the alkaline Irrigate. I mean, we would put in 2 liters in each eye if we have an alkaline burn, because that gets in there, continues to burn, continues to damage the cornea, and can cause a lot of problems. And then on the ruptured globe, you put a patch over the eye, but you don't want to put pressure on it, because you can push your intraocular fluid out of the eye.
Absolutely, you have to protect it.
We would have them cover it up, not don't double it up like you used to do with the eye patches, but they put it over the top of the eye and just protect the eye from any outside contamination, but don't put pressure on it.
Absolutely. Thank you. So for dental trauma, those are, so just briefly, average adult has a 32 teeth. Sections of the teeth are just crown and root. It has a hard and soft tissue. Injuries include concussion, subluxation, extrusions, intrusions, avulsions, infarctions, different types of fracture with or without pulp involvement. So these are just pictures of intrusion and alveolar fracture. So those are to look for. And also I'd like to point your attention to these two. Enamel dentin pulp fracture or complicated crown fracture. You see there is a miss of part of the tooth is missing, and it might be somewhere in the oral cavity, so you do have to look for those foreign bodies for those teeth and make sure the patient is not aspirating those. Also avulsion, when the tooth is completely displaced out of its socket. So again, it might be somewhere in the oral cavity, and you have to make sure that its patient is not gonna swallow it, especially in an unconscious patient. Patients are actually allowed to carry those teeth in their mouth during the transport if they are awake and alert, and they can keep them between the buccal mucosa and the in the mouth to prevent that viability. If patient is unconscious, you can put that tooth in if found, in a saline container. So, pre-hospital care. Few words about pre-hospital care. So facial trauma can present some of the most challenging injuries that pre-hospital care providers are called on to manage. As with any trauma patients, complete a thorough scene size up and begin C-spine stabilization if it's indicated. During the initial assessment, and then identify and begin to manage your ABC life threats. Those are it's either absent breathing, compromised airway, if patient has an absent pulse or severe bleeding, so those need to be addressed first. Facial trauma may also be associated with other injuries that place the patient's life in jeopardy, so make sure you look through the entire body and sort all injuries that patient might have. Finally, these injuries may be disfiguring, which may distract you from recognizing and addressing more serious conditions. So just keep in mind, not only evaluate the face, because it's the most vascular place and can have extensive bleeding, just make sure you completed the entire body survey. So management of the facial trauma is, as I said, it's not different from any other evaluation of the trauma patient. It starts with primary survey, and it's your rapid assessment of vital functions. Make sure that you identify all life-threatening conditions. Followed by a secondary survey, and that's where you examine patient head to toe and see if you can identify those obvious injuries that needs to be addressed while patient's being transported to the appropriate level of care. And start appropriate interventions. So what include primary survey? First of all, it's an airway breathing evaluation. The primary survey begins with the assessment of airway patency. When the provider first sees the patient, numerous clues may point over an inadequate airway. When lying down in supine position, an unconscious patient is at risk for airway obstruction from the tongue as it relaxes and falls back to block the airway. You might hear noisy breathing or high-pitched noises indicating partial airway obstruction. The airway may be compromised by broken or avulsed teeth and fragments of bone. Patient also can be vomiting, and that can obstruct his airway as well. Because of the tongue is attached to the mandible, fractures of that bone may predispose the tongue to block the airway, and especially if mandible is broken in two locations. Facial fractures such as injury to the maxilla or mandible may cause mechanical obstruction, and that can result in associated hemorrhage. Penetrating injuries such as those caused by a gunshot wounds to the face and severe facial fracture may disrupt blood vessels deep within the facial skeleton and result in a hemorrhage that may pull in the airway. This blood may drain extremely through the nose and mouth, but it may also be swallowed by an unconscious patient, so injury to the arteries of the face can produce an expanding hematomas that may grow to occlude the airway. Nasal flaring at the And the use of accessory respiratory muscles, such as strap muscles of the neck, indicate the patient is struggling to breathe as well. Conscious patients with facial injuries will typically find the position that facilitates breathing. You might find them sitting up and leaning forward, and they may become combative if you force to lay supine. With the exception of the airway compromise, facial trauma does not impair oxygenation and breathing. So then when you see a patient with a facial trauma that have a difficulty breathing, make sure that your patient has a patent airway, and maybe this patient has a occult airway obstructions. Patient might have a pulmonary contusion or pneumothorax, so you need to assess for those as well. Do not only concentrate on the facial injuries, make sure that patient is not suffering airway obstruction from something else. Your C for circulation. So the face and scalp possess that high concentration of blood vessels, so even that small wound can produce dramatic hemorrhage. So more serious wounds can result in a life-threatening hemorrhage, like let's say degloving injury of the scalp. The large portion of the tissue is peeled back of the skull, and that may result significant external hemorrhage, and patient can actually go into decompensated hypovolemic shock. Make sure that the trauma to the face will be evaluated. So make sure that you perform a Glasgow-Coma scale score, because patients often have a traumatic brain injuries associated with the facial trauma. Also they can have a spine or spinal cord injuries. Make sure that you assess pupils for symmetry and reaction to light. And if patient has a depressed GCS score combined with unilateral dilated pupil and lateralizing signs, then patient may have an intracranial hematoma, subdural or epidural. Make sure that you reassess this patient every 15 minutes for GCS score. And you also want to expose this patient. Make sure that you remove all the heads or caps, so you can examine the entire scalp and visualize and palpate that. Consider removing any protective gear, especially those, especially helmets, but use a proper technique to remove those, so you can reevaluate patient completely. Your secondary survey is a complete head-to-toe assessment of the patient. And you want to make sure that you address all the obvious injuries. It's performed only after the primary survey is complete and all the life-threatening conditions are ruled out or corrected. If it's a conscious patient, you can ask him questions about their injury, what happened, what kind of mechanism that patient underwent. Ask him if he has any visual changes, if he has double vision, if his hearing is affected, if he has any numbness of any location, anywhere in the face. Ask him about the pain. Ask him to open and close his mouth in order to figure out if patient have a mandible fracture or not. And he can also report that he has a misalignment of the teeth, or as we call it, malocclusion. So those are kind of clues that patient can have a facial fractures. You should palpate the face and all of all patients that are being injured. Inspected for soft tissue injuries, any deviation of the nose or asymmetry of facial structures such as cheekbones and the mandible is noted. The oropharynx should be examined for evidence of broken teeth, foreign material or swelling of the palate or floor of the mouth. Clear fluid draining from the nose or ear canals, maybe that CSF fluid that we talked about earlier, and that can indicate of basilar skull fracture. So I would suggest to palpate face gently and look for signs of tenderness and bony step-offs or crepitation. Make sure you not displace them more than they already are. If patient is unconscious, you can put a glove finger into the mouth and the maxilla and gently pull forward. So you want to inspect for instability of the bones of the midface. Also, don't forget that you can ask patient to look different directions and examine for extraocular movements. If you find any deficit in extraocular movements, those may result in a nerve injury or interruption of the muscles that move the eye. And you can actually quickly test trigeminal nerve, all its branches, by lightly tapping over the forehead, over the cheekbone, and over the mandible. And any decreased sensation or any decreased sensation would actually kind of steer you towards the injury to that nerve. Branches of the facial nerve can be tested by asking the patient to sequentially wrinkle their forehead, puff their cheeks, close tightly their eyes, ask them to frown or smile, and show their teeth. Any abnormality in those can also signify that cranial nerve number 7 facial nerve injury. So what are the steps in the management of this patient in pre-hospital settings? Like most other injuries, definitive diagnosis and management occur in the pre-hospital settings. In the hospital setting, sorry. In the pre-hospital settings, place emphasis on establishing and maintaining a patent airway and controlling external hemorrhage. These actions can be life-saving. When caring for a patient with facial trauma, the provider's high priority is to ensure a patent airway. Some conscious patients with severe facial trauma may be able to successfully manage their airway themselves. Although potential spinal injury is a concern, these patients may become combative if forced to wear a C-collar or lay supine on a long backboard. These patients can be transported in the position of comfort and generally sitting up, and you can even give them suction device and allow them to suction fluid from their airways themselves as needed. If the patient allows, you can maintain that stabilization of the head and neck during the transport. If patient is unconscious, essential airway skills are initiated while another provider applies manual stabilization of the head and neck. The mouth may be opened with a modified jaw thrust maneuver. Teeth and regurgitated food particles are swept from the mouth, and suction is used to remove blood, and maybe, as I mentioned, those teeth. If transport times are brief, the airway may be successfully managed with insertion of oral airway, or you can use the BMV device, bag valve mask device. Don't forget to repeat suctioning while in transport. For longer transport time, the airways is placed or endotracheal intubation is performed. Use of BMV may fail to ventilate a patient with severe facial trauma because an adequate seal may not be possible with severe soft tissue injuries that involve the mouth. If you can ventilate via either approach, consider performing needle cricotiotomy and transtracheal ventilation, or even get ready for the surgical cricotiotomy if that's what your protocols allow. The airway should be reassessed as frequent intervals because facial trauma may have occult airway injuries, or progressively develop an airway obstruction. They may also have associated thoracic injury that can also contribute to that impaired oxygenation and ventilation. Use pulse oximetry and administer oxygen to maintain oxygenation at above 95%. Another priority is to maintain circulation. These patients with facial trauma frequently experience external hemorrhage. Most bleeding from facial injuries can be controlled with the firm, direct pressure of the site of the bleeding. Extensive scalp bleeding may be controlled with the application of a pressure dressing, and those can be created out of gauze sponges or an elastic bandage. Unlike the bleeding from the extremities, you cannot apply tourniquet to the neck because that will decrease your blood supply to the brain. If bleeding continues from the oropharynx after intubation or cryotherotomy, the mouth can be gently packed with a gauze that you can do from a roll. This may help tamponade bleeding from the mouth. If significant bleeding is coming from the nasal openings, pack these may only result in blood pooling in the hypopharynx. On rare occasions, vascular injuries in the face cause that significant hematoma that extends down into the neck or even supraclavicular region. There may be a little external bleeding that you can see, but anatomic distortion of the pharynx and neck from such bleeding can make intubation and cryotherotomy difficult. So in such circumstances, if that medical facility you are trying to get this patient to is close by, then definitive airway management is the best defer until that patient reaches that facility. But make sure that there are certain conditions that this patient has to meet. Patient has to be conscious, protective their airway and breathing, and his oxygen saturation should be maintained about 90%, above 90%. Or you can ventilation can be performed without difficulty using a rescue airway, or like let's say LMA, or bag mask with a again oxygen saturation above 90%. And don't forget to notify the receiving institution of patient's condition so that emergency department can get ready for that difficult intubation. If patient has a signs of shock, start IV volume resuscitation. Titrate IV fluids to maintain systolic blood pressure in the 80 to 90 millimeter or mercury range. If you will try to give more aggressive volume with crystalloid solution, that may worsen that hemorrhage by disrupting blood clot, or it can dilute blood clotting factors. So transport must never delay supply. So never delay transport the patient to the emergency room. If you need to put the IV, you can always do it during transport. If transport is prolonged due to long distances to a medical facility, you can irrigate wounds with the saline. You can even brush dirt and other debris from a wound using moistened gauze pad. What else? Because many patients with the significant facial injuries have concomitant trauma, TBIs, traumatic brain injuries. You must frequently reassess their neurological functioning. So repeat those CSF scores and papillary response. Make sure that patient is still neurologically intact. Avoid hypoxia and hypertension because these factors are known to worsen the outcome of the patient with TBIs. And anemia can also contribute to the secondary brain injury, so underscoring the need to control external hemorrhage. Finally, all the more minor facial injuries can be satisfactorily managed at the most community hospitals. Definitive management of complex facial trauma often requires the skills of numerous surgical specialties, and those include plastic surgery, maxillofacial surgery, ENT or otolaryngology, and ophthalmology. And these patients are probably best managed at the level 1 trauma centers, as we're here at the University of Utah, or level 2 trauma centers. There's special consideration I'd like to point your attention. If you suspect a ruptured globe, protection to prevent compression of the eye or should be placed on the field. And as Ras has mentioned that earlier, yes, you do want to protect the ruptured globe. Avulsed tissue, including ears, the tip of the nose, or large skin flaps, those should be transported with the patient in saline-soaked gauzes. Full-thickness skin flaps are often more readily reattached to the face than the other body parts. Therefore, every time when you in doubt about viability of avulsed tissue, they should be transported with the patient. Avulsed teeth should be transported with the patient as well, and as I mentioned earlier, patients with a normal maintenance status who are able to protect their airways may be allowed to carry avulsed teeth in their mouths. But those who are intoxicated or otherwise altered complain of nausea or vomiting, and those who require cervical spine immobilization, those cannot transport those who cannot be transported upward, in other ways. Those are at risk of aspiration, and they should not be allowed to carry teeth in their mouth. So you will place them in a sterile saline container, in a container with a sterile saline solution. If you see tooth that is incompletely avulsed, just leave them in place and do not manipulate those teeth. As far as impaled objects, those should not be removed unless they're causing, again, airway compromise. So stabilize and to prevent further injury during the transport. With the avulsed tissue, if it's completely separated, your goal is to control bleeding with direct pressure, retrieve avulsed tissue if possible, rub that tissue in a gauze. It can be either dry or moistened with the lactate ringers or saline solution, whatever your protocol says. Seal tissue in plastic bag and place seal bag on a crushed ice. So in summary, facial trauma most frequently caused by motor vehicle collisions, physical altercations, and falls. You're the first only to assess for and treat ABC life threats due to the facial trauma. Remember, life threats can come from injury to the other body system. Maintaining an open airway is the most significant treatment challenge in facial trauma patient, and deliver that patient to the most appropriate level of trauma care. So in conclusion, management of the trauma victims with facial injuries can be very rewarding. By keeping wounds clean, maintaining open airway, and providing control of that hemorrhage, you become an integral part of the patient's care. Your interventions may be just as important as that of the plastic surgeon who will suture the wound, repair that fracture, or ophthalmologist who will repair the eyes. And that will conclude my presentation. Any questions? Any questions?
I think you covered it all.
All right. Thank you very much.
Thank you.